Okay, well, welcome to Renal Rad Path. My name is Matthew Hartman from Pittsburgh, PA, part of AMSR. Again, all these lectures can be found on the ACR building block site. Our Anki deck can be found with instructions on the YouTube channel. So this comes from a RSNA presentation about the GU alphabet soup. And as we'll see, there are lots of terms which sound similar, and we're going to try and make sense of it. So let's start with a quick GU imaging tutorial. For GU, you can divide it into reproductive and non-reproductive organs. We're really going to focus on the kidneys, ureters, and bladder. So how do we study that? Well, ultrasound. Using sound waves to define the anatomy, look for stones, mass, and collecting system dilation. Remembering that things that are echogenic or bright include air, fat, and calcium. Things that are anechoic will be completely black. This is water in a cyst, or a dilated collecting system with hydronephrosis. Renal cysts are very common, and it is imperative to distinguish a cyst from a solid mass. Remembering our first RadPath lecture, if you can categorize a lesion as cystic or solid, you're off to a great start. Here is a renal lesion. It's completely anechoic. There's positive through transmission, thin imperceptible wall. This is a cyst or a bag of fluid. Same pathology, but on CT. We use Hounsfield units. Water will be 0 Hounsfield units. Here, very close to Hounsfield units. Switch into MRI. We are on T2. The CSF is bright, hyperintense, and so is our renal lesion. T2 hyperintense renal cyst. Autosomal dominant polycystic kidney disease, too numerous to count cysts in both kidneys. The kidneys are enlarged, and this is what it looks like grossly. Dilated collecting system. This is the same patient at 2 different time points. Here we have a collecting system which is filled with urine. It has become dilated. This is hydronephrosis. Note the kidney is also increased in size. It's 12.7 centimeters here, whereas the non-hydronephrotic state, it was 10.6 centimeters. Here's an example on MRI. Dilated collecting system on the right to the level of the renal pelvis, UPJ obstruction. Here's the gross path correlate. To study the kidneys often helps to have contrast. We'll have a separate module on contrast, uses, indications, contraindications. But let's start off by defining it. Contrast is a material used to enhance an internal structure, outline walls, define anatomy, and especially important for GU imaging. And we can use contrast with CT, MRI, and we've actually started using contrast for ultrasound, little gas particles. So how does contrast work? Remembering our basic physics, materials with a high atomic number, such as gadolinium, iodine, and water-soluble contrast agents for CT, and barium, will absorb X-rays and will be radiopaque on the radiograph. So here are the 3 substances, gadolinium, iodine-based contrast, and barium. When we X-ray them, again, all radiopaque, and when you look at what they actually look like, one looks like milk, one looks like ginger ale, one looks like water. But the X-ray never lies, they're all radiopaque. Here's a CT with contrast showing our renal mass in the lower pole. Here's MRI with gadolinium contrast showing a big innie in the bladder. This was a TCC. This is one of my favorite cases. This is a patient with left-sided flank pain, and they did a CTU protocol. So we have the non-contrast scan, and the stone shows up very nicely. We give contrast. We're in the corticomedullary phase here, a little bit harder to see the stone. Then we wait 5 minutes to be in the pyrographic phase. The kidneys are excreting contrast, and the stone has disappeared. It's the same density as the contrast, so to our eye, it looks like it's disappeared, but realize it's hiding out there. So that's why it's so important to understand what phase of contrast you're in and to know what you're looking for on those different phases, or else you'll get faked out. So let's go through the alphabet soup of GU pathology. Again, you can go through this on your own time, go back and forth between the different pathologies. I'll be showing an overview. So our first is acute cortical necrosis. This is a patient who's had big time trauma, big time blood loss, gets resuscitated, but the cortex, which has a different blood supply, had become necrotic and is not enhancing, as opposed to the medulla. Chronically, this will often calcify and you'll be left with cortical nephrocalcinosis. We will contrast that with medullary nephrocalcinosis. We've seen this already, autosomal dominant polycystic kidney disease, cysts in the bilaterally enlarged kidneys, cysts in the liver, can be also seen in the spleen or pancreas. Common cause of chronic renal failure, often requiring transplant. Angiomyolipoma. For an ultrasound, we have an echogenic lesion. If we remember what is bright on ultrasound, fat, calcium, or air, we get the CT showing this is a fatty lesion, approximately negative 100 Hounsfield units, AML. Autosomal recessive polycystic kidney disease. This is more of a pediatric diagnosis, where instead of those macrocysts, we get a bunch of microcysts. And again, in the pediatric population, will often present as a hyperechoic, enlarged kidney. Medullary sponge kidney. I think of this as tubular ectasia. The renal tubules are more dilated than normally. We can actually see them on the gross specimen here. And when we image it, you can actually see the tubules, which sort of look like the top of a paintbrush. This is called the paintbrush sign. Realizing that throws off the flow mechanics for the filtration system, more calcium can precipitate out. We're in the medullary portion of the kidney and will often get medullary nephrocalcinosis. Other conditions that can be seen with medullary nephrocalcinosis are hyperparathyroidism and renal tubular acidosis. This is a great differential to know. Multilocular cystic nephroma. The name says it all. Multilocular, multiple septations and locules. It's cystic. You measure this, we'll get less than 20 Hounsfield units. And nephroma, there is a cystic neoplastic process going on. So young boys, older females are the age demographics that get this lesion. It can herniate into the renal pelvis, which can sometimes help us distinguish it, but ultimately, this looks very similar to our next process, multilocular cystic RCC, such that radiographically, we cannot distinguish between these two entities and have to give that differential. 10% of RCCs are cystic and can look like this. Renal artery stenosis. We can see this in native kidneys or transplant kidneys, a common cause of hypertension that can be treated. The etiologies are atherosclerosis, usually seen at the ostia, or FMD, fibromuscular dysplasia, seen more in the mid portion of the renal arteries. The treatments will be different for atherosclerotic renal artery stenosis, be treated with angioplasty and stenting, whereas fibromuscular dysplasia is treated with angioplasty without stenting. And this has been likened to the string of beads sign. But in both examples, it causes luminal narrowing. The velocity through the stenosis is very elevated here, over 600. And then downstream, you get the parvus tardus waveform. Renal cell carcinoma, RCC, common. 90% of the time occurring in the proximal convoluted tubule. Can be complicated by necrosis, cystic formation, calcification, or hemorrhage. Risk factors: smoking, obesity, dialysis, and certain genetic conditions such as von Hippel-Lindau disease. The classic presentation is hematuria, flank pain, and mass. Can be associated with paraneoplastic symptoms of hypertension and hypercalcemia. This is the value of contrast. On non-contrast, it may be hard to see the lesion unless you notice that the border is deformed. We give the contrast, much easier to see the lesion. And we do a multiplanar reformat, and even easier to see this lesion. So solid renal mass, you measure the Hounsfield units, we're going to get about 50 or 60. And this is our cover case for RadPath. This is a chromophobe renal cell carcinoma, one of the rarer subtypes of RCC. The staging for RCCs. For the Robson staging, stage 1 confined to the kidney, stage 2 within Gerota's fascia, 3A going to the renal vein or IVC invasion, 3B involving lymph nodes, and C involving lymph nodes and vascular invasion. I like to talk about tumor tipping points with my RadPath students. You can imagine that renal vascular invasion is a tumor tipping point that the urologist would like to know that if the tumor is going to the renal vein, and especially if it's going into the IVC and heart. This will change surgical management. We'll have to get vascular surgery here and may have to get cardiothoracic surgery if it's going into the IVC and heart. And of course, the tumor tipping point of metastases. Always looking for metastases with the cases of RCC, looking for bony lytic lesions. Next, renal papillary necrosis. This is a condition where the renal papilla here actually cavitates out. What's causing it to cavitate out? Sort of like a cavity in your tooth. This is one of my favorite mnemonics, NSAID. The most common thing is actually NSAIDs. That's why it's such a great mnemonic. But anything that can cause vascular compromise to this tenuous area here, again, the NSAIDs can do that, sickle cell disease, other analgesics, infections, especially TB, love this area and sort of eat that area out, leaving you with a big cavity, and then diabetes working on the microvascular level. And what we're left with when we administer contrast is we'll have some extra calyceal contrast here filling in. And this might look like the golf ball on T sign. We got our club calyx here, and we got our golf ball sitting on top, filling with contrast. Renal vein thrombosis. So we talked a little bit about the staging of RCCs and the tumor tipping point that goes into the renal vein and IVC. That totally changes surgical management. Realizing that other tumors that like to go into the renal vein, RCC, TCC, Wilms tumor, and adrenal cortical carcinoma. TCC, or transitional cell carcinoma. We saw this case earlier, a big INI in the bladder. Here it is on gross path, big INI in the bladder. And the risk factors, we remember from step 1, aniline dyes and smoking. One thing with TCCs, they often like to be multicentric. So if you see it one place in the bladder, look in the collecting system in the renal calyces and renal pelvis. UPJ obstruction. We have an obstruction at the level of the renal pelvis. This one caused by a crossing vessel. What's it going to do on ultrasound? Our collecting system gets dilated proximal to that point. So things that can cause obstruction, neoplasm, crossing vessel, like here, calculi, and some congenital malformations. This is a UPJ obstruction in contrast to a UVJ obstruction at the level of the bladder ureter insertion. Again, our differential can have a calculus at the UVJ or can have a tumor, in this case a TCC. Again, all this is plumbing. Everything will get backed up proximal to that. One of my favorite entities, XGPN, xanthogranulomatous pyelonephritis. The triad, you get a staghorn calculus with an enlarged hypofunctioning kidney. This kidney is not doing anything. It barely enhances, and we got this dilated collecting system, which if you put a needle in there, you would get these lipid-laden macrophages, just a chronic granulomatous process going on. And this has been likened to the bear paw sign. Pads for the bear paw there. I like this case a lot. We see a normal functioning left kidney here, which is excreting contrast. And then we get our abnormal right kidney, which is enlarged. It's hypofunctioning. There's a staghorn calculus as well, not in this field of view. But the complication to be aware of is the infection can seed and go to adjacent structures, here going to the right iliopsoas muscle. So that was a quick tour through the GU system of pathology. We hit some of the highlights. Again, I encourage you to take a closer look at the whole presentation, go back and forth, and think about those tumor tipping points. If you have a lesion, think, is it solid or cystic? And again, look for those patterns of pathology: INI, outie, narrowing, dilation, thickening, and displacement.